Dr. Lawrence has over 25 years of experience. He is a professor with the University of Florida and works in the care of pediatric HIV and others that are HIV infected and exposed. He has clinics in other areas in the state of Florida, to include Tallahassee, and we are very happy to have him here this morning. This is sort of the second part of two sessions. Our last session, we talked about identifying and caring for the HIV-positive pregnant woman, and this morning where we'll talk about her exposed infant. Dr. Lawrence doesn't have any financial relationships with commercial entities to disclose. He will not discuss off-label use of newer medications. Dr. Lawrence, I'm going to let you get started.
Thank you, Millie. Good morning, everyone. This is a topic that I definitely get excited about, and part of the reason is because I've been working in this arena for the last 25 years. So I hope that we can enjoy some of the information I'm going to try and share, but I am definitely looking forward to questions from the audience or comments and thoughts, because I do think this is a pretty important topic. Certainly our overall goal is to decrease the number of HIV-infected infants born in Florida. Perinatal Project's objectives really are to make sure that everyone, men and women, know more about perinatal HIV transmission prevention, to increase the number of providers who do routine prenatal HIV screening, and to increase the number of hospitals across the state that do rapid HIV screening in labor and delivery. I'm going to go over a few things that are somewhat of a review before we jump into the particular care for the infant. I think you probably all recognize routine testing, diagnostic testing, screening, and targeted testing. And you know that in this era, the majority of our testing is routine. That is, for example, in the prenatal visits, or diagnostic, trying to actually diagnose an individual with HIV. Additional definitions include informed consent, which I'm sure you understand from your use in other healthcare venues. Opt-out screening is very important relative to HIV screening. It is really the idea that you present that the test will be performed to the patient, and you advise them that they can elect to decline it or defer it. And if they don't decline, then assent is inferred. Now, having said that, I think it's very important how you actually present that. And one of the ways that I do it, particularly when I see women in preconceptual visits or prenatal visits, because I do see women to talk about the issues related to their infant during pregnancy. And the thing that I say is that I'm extremely happy that they're coming to see me, that I feel like it's a real opportunity for us to start to work together so that they can have a healthy infant. And the issue about the test is I recommend this test to every woman, just like I recommend hepatitis B testing or syphilis or gonorrhea. And why do I recommend them? Because I know we can treat every one of those and we can protect the infant, and this allows us to have healthy infants. And so that's my emphasis on that. And then finally, HIV prevention counseling is usually a more interactive process, but often a process that occurs over several healthcare visits. And it's really about recognizing risk, recognizing specific behaviors that increase that risk of transmitting or acquiring HIV, and then having a very specific plan that the individual can do to reduce risk. Some of the continued obstacles to eliminating perinatal transmission in the United States include the increased number of women who are HIV infected during childbearing years, absent or delayed prenatal care, particularly in women who use illicit drugs, or even in women who have mental health issues. Acute primary infection can occur during pregnancy and in women who are breastfeeding, and this is a particularly high risk for transmission. Poor adherence to the prescribed antiretroviral medications, and then lack of full implementation of routine and universal prenatal HIV counseling and testing. Transfer perinatal transmission represents the transfer of the HIV virus from mother to infant during pregnancy, during the birth process, during breastfeeding, or even with feedings that are pre-masticated by an HIV-positive adult and then provided to the infant. Here are some of the key components to preventing and identifying the important steps in perinatal HIV prevention. Obviously, testing is at the beginning with early identification. The repetition of testing in the third trimester, exceedingly important. We continue to see in the children who are infected, quote, those missed opportunities. Many of them are because testing was not repeated in the third trimester. And certainly rapid testing can occur in labor and delivery. The antepartum care is also crucial in terms of assisting with the pregnancy and the health of that pregnancy, but also the focused care for HIV care for the mother. Part of that care includes antiretroviral medications for the mother, as well as the discussion of cesarean section versus vaginal delivery for each individual woman and discussing the different situations that she might encounter. Postpartum care involves linkage to care that absolutely has to be for both the mother and the infant. It's not linkage to care just for the infant. It's both mother and infant so that mother continues to remain healthy. And then neonatal care involving universal precautions, ARV prophylaxis for the infant, and then testing of that infant to document their status. So these are all crucial to any plan for perinatal HIV transmission prevention. This slide is about the Florida law for HIV and STD testing in pregnancy. It notes that it is also in agreement with recommendations from the CDC and ACOG, and it's strongly supported by the AAP as well as AWHONN. So many agencies and groups are recommending this, and you should consider this the standard of care. Prenatal testing requirements include testing for chlamydia, gonorrhea, hepatitis B, HIV, and syphilis at that first prenatal visit. Again, this should be done via opt-out testing. The testing should be repeated again at 28 to 32 weeks gestation. And then if there's no documented test result for an individual woman, then rapid testing should occur in labor or within the first 30 days postpartum. Ideally, it can occur within the first 4 to 6 hours. And with that information, then additional intervention can be provided for the infant if needed. Obviously, notification of testing is crucial. Just because you test the woman, if she's not aware of her status or she does not continue in prenatal care, then we've sort of missed the boat on that level. So we notify her at the beginning of which tests we're going to perform. We inform her of her right to, quote, opt out or refuse any and all tests. And if she does refuse, we ask her to sign a statement stating that she has been offered these tests, does refuse. If she does refuse, it's also pertinent for you as a healthcare provider to document this in the medical record. In terms of explaining the risk of perinatal HIV transmission, this slide represents the numbers that I commonly use with mothers, parents, or families. And there are a couple things you'll note about it. One is at the top I use a denominator of 100. So 24 out of 100 infants will become HIV infected if there is no intervention taken during pregnancy, during delivery, or for the infant. And it does also include the idea that there is no breastfeeding. If in a situation, if breastfeeding occurred, then the risk is even higher than 24 out of 100 or, quote, 24%. When we do have the opportunity to provide at least zidovudine to the mother and the infant, the mother receives it during pregnancy, it is given during delivery, intrapartum, and the infant receives it for 6 weeks postnatally, then the risk of transmission is decreased to 6 to 8%. That's a 2/3 reduction in the risk. In this era of HAART, highly active antiretroviral therapy, mothers receiving HAART can get undetectable viral loads. When that is done, and the other steps of providing zidovudine intrapartum and providing zidovudine to the infant postnatally, in that scenario, you can decrease the risk of transmission to that infant down to 2 to 3 out of 100, or 2 to 3%. And that's a 90% reduction from doing nothing. The other two lines here are about what the risk is with testing. And so current testing recommendations are to test infants who are exposed to HIV with an HIV DNA PCR test at 2 to 4 weeks and 4 to 8 weeks. If both of those tests are negative in an individual infant without any other positive tests, not counting the ELISA, then the risk to that infant is 2 out of 1,000. That, in fact, is 10 times less than the number when the mother receives HAART and all the other steps of perinatal HIV prevention. So this is one of the things that I really emphasize with parents, that we really need this testing afterwards. It's crucial to go through all of the other steps, but testing is an additional, of the infant is an additional important part of our prevention plan. And then finally, if the infant has ELISA antibody testing for HIV, which is negative after 12 months of age, then in fact that infant has 0 risk. And this is the number that I say to parents, I know you want to hear that your infant has no risk, that you can stop thinking about this and stop worrying about it. And I remind them that that's the number I want to hear also. And so that together we can go, if we can go through all the steps and do each of these steps, including the testing, up through 12 to 18 months of age, then we can all know that this infant is no longer at risk of perinatal HIV transmission. This is just a summary slide of the Pediatric AIDS Clinical Trial Group Trial 076. It reminds us that zidovudine is provided in all 3 arms, and as was done in that trial, antepartum to the mother beginning at 14 to 34 weeks of gestational age, intrapartum IV zidovudine throughout labor and through the delivery, and then postpartum zidovudine to the infant. The dosing there, 4 milligrams per kilogram orally every 12 hours for 6 weeks, was changed in 2011. And so that is the current regimen. It's a little bit easier for moms to do or parents to do every 12 hours. One thing that should be noted is, in my experience, I have never seen an infant refuse liquid zidovudine. If mothers are saying that's a problem, then you either need to look for a medical problem in the infant, or you have to do additional support for this mother, because it's not about the infant not taking it. There are other situations, prematurity, where infants are unable to take oral medications, and IV therapy can be used, and there are different dose adjustments for that. And then finally, that re-emphasis that no breastfeeding is part of perinatal transmission prevention. These are the results from that trial, and I think you can either look at the table on the right and recognize that testing was done at different time periods, 0 through 72 weeks, and the difference there between the percent of infected children with zidovudine, 8.3%, and versus placebo, 25.3%. And that transmission rate for zidovudine is in that ballpark that I mentioned above, 6 to 8%. That is that 2/3 reduction in risk transmission, and clearly this was a significant value statistically by Kaplan-Meier plot. This is another study, the Women and Infants Transmission Study, which involved over 1,500 women back from 1990 to 2000. In this study, in specifics, when no prenatal therapy was given, there was a 20% transmission rate of HIV to the infants. If only zidovudine monotherapy was used, then the transmission rate was decreased by half, down to 10%. If the mother received multiple drugs during pregnancy, then the transmission was just under 4%. And if mother received highly active antiretroviral therapy with a good response decreasing her viral load, then the transmission rate in those infants born to those mothers was 1.2%. So you can see that in different studies the numbers are slightly different, but clearly in this era when we can provide heart antiretroviral therapy to mothers, then we can get that transmission rate down to less than 2%. And this is additional data from that study, which just reminds us that viral load is clearly related to the rate of transmission. And as you go from the top, where the viral load of a mother is under 400, down to the bottom, where the viral load is over 30,000, you can see that transmission rate going up stepwise. And again, back up to that transmission rate in the 20% range. This is just an emphasis of postpartum zidovudine prophylaxis for infants, because we are talking about what to do for the exposed infant. And this just reinforces the new guidelines of 4 milligrams per kilogram orally every 12 hours. If you note the previous dosing right below it, the dose of zidovudine per day is the same. It's just that it's now given every 12 hours. Again, the pharmacokinetics support that. Prevention trials support that, and this is easier for families to do. And finally, at the bottom is the website for those most recent recommendations from September 2011. This slide depicts what would be routine care of the HIV-exposed infant from birth through 18 months of age. At each juncture, birth 2 to 4 weeks, 4 to 8 weeks, 4 to 6 months, and 18 months, there should be a history and physical exam done, looking for illness suggestive of HIV, looking for hepatosplenomegaly, lymphadenopathy, rash, or poor growth as significant findings that one might see in an HIV-infected infant. The antiretroviral therapy is just emphasized again as continuing from birth through 6 weeks, and then it stopped. Testing of the CDC and differential along with HIV DNA PCR or HIV RNA PCR is recommended at 2 to 4 weeks and 4 to 8 weeks. And those are the recommendations. You can see the plus minus at birth and the plus minus at 4 to 6 months. And honestly, that we still do that testing at birth and again at 4 to 6 months in Gainsville. And I know a number of HIV pediatric specialists around the state do continue to do that. And then finally, that ELISA testing at 18 months with the hopes of confirming that that infant status is in fact not infected and the risk is then 0. And then PCP prophylaxis, many of you may remember that we used to give this routinely to all exposed infants beginning at 6 weeks of age through 6 months of age. But now that is simply a recommendation based on getting your results from the 2 to 4 week testing and the 4 to 8 week testing. And if either of those tests were positive or there was a question about their positive status, then you would begin PCP prophylaxis to protect that infant. One of the reasons to remember that is because it doesn't matter what the infant's CD4 counts are. They are being exposed and acquire PCP at usually between 4 weeks and 6 months of age. And if they are fighting or becoming infected with HIV, they can develop pneumocystis carinii pneumonia and get very sick. So in any infant where there is concern about their status and you're worried that they are in fact positive, then you should consider PCP prophylaxis in that infant. This slide depicts the decline in perinatal HIV transmission over the years. The colored dots provide you with significant points in time, and you can see that in 1993-94, even before the results of the PACTG trial was available, the rate of transmission had already begun to decline in Florida. Part of that was because there were a number of pediatric HIV specialists in Florida participating in that trial, and they began to institute the regimen because they could see already that the results were decreasing transmission. The other important points there are public health service recommendations for the guidelines for this perinatal HIV prevention. 1995, the CDC came out and recommended counseling and testing for all women. In 1996, mandatory offering of HIV testing became law in Florida. And then in November of 2006, routine testing became law in Florida. And you can see over those years the decline in transmission has been very, very significant. This is part of why we need to continue doing what we've been doing, but also continue to focus and make sure we're doing it in every hospital around the state, in every situation where pregnant women are cared for and infants who are exposed to HIV are cared for. This slide depicts Florida and shows you the different years from 2007 to 2012. The number at the far left, 17, 12, 9, 6, 3, and 7, represent the number of infected infants in each of those years. And the marks or identifiers, diamond and star, et cetera, note the location around the state where those infants were infected. You see that we had a continuous decline from 2007 to 2011, and then that slight bump up in 2012. This is another reason for us to stop and think about how we're providing care and think about all the steps for perinatal HIV prevention that we do or that we participate in our various locales, and to reinforce and ensure that we are providing each one of those steps and we're doing it in the best way possible for every mother and every infant. Rapid HIV testing to prevent perinatal transmission, often recommended in the labor and delivery when the mother does not have a documented test, has been studied in Florida. It was studied by Dr. Helfgott and his group. The reference is down in the lower left-hand corner. And these are the results from that study where testing was reviewed in over 1,700 women. And there were 2 women who were confirmed positive. Interventions were initiated at that time, meaning in labor and delivery. That is, providing intravenous zidovudine to the mother during labor, and then the infant was provided oral zidovudine for 6 weeks after that. Both of those children were subsequently negative. In this study, there were 2 false positives with subsequent Western blots negative. Both of those infants were initiated on zidovudine, with that being that window of opportunity for us to prevent transmission. And then once the Western blot confirmation testing returned as negative, then zidovudine was stopped in both of those infants. So this study was a great example of the use of rapid testing in labor and delivery. It proved its viability in a local setting. It proved that one could actually institute interventions to prevent transmission in infants, and it also demonstrated that even when we do have false positives, the steps are appropriate to prevent transmission at that time. Evaluation and follow-up of HIV-exposed infants. I showed you that before on the table, but this just reemphasizes those steps. Providing AZT, quote, prophylaxis for that infant for 6 weeks. It's called prophylaxis because the infant is not known to be infected yet. The HIV diagnostic testing, which was the HIV DNA PCR or RNA PCR at 2 to 4 weeks, 4 to 8 weeks, and then subsequent ELISA testing at 18 months. Part of that evaluation and follow-up of infants should be the referral to an HIV specialist, ideally an HIV specialist who has experience with children. Consideration of PCP prophylaxis should be done at 6 weeks if any of the testing was positive or suspected to be positive. And then it's very important for continued long-term follow-up for the HIV-exposed infants, and in part also because they are exposed to the antiretroviral therapy. We continue to follow infants out to 2 to 3 years of age, observing their growth and development and monitoring that and assessing that along with pediatricians. And then finally, and a crucial part of this evaluation and follow-up is support services for the whole family, support services in line with continued treatment for the mother and for that follow-up for the infant. Case management services within communities is essential, and this is part of that support for the family. Those services should be provided throughout pregnancy. That should include education for the mother and for the rest of the family on the plan of care, the various steps, re-emphasizing the fact that we can prevent transmission if we can provide all of these interventions and steps. This case management should facilitate referral to HIV specialists and facilitate referral for ongoing testing in the infant. It will assist in the obtaining of AZT and nevirapine if indicated for the infant, and particularly noting Baby RX Express program, which will make available AZT in locales wherever infants are exposed to HIV, period. This is an important program. Many hospitals say, oh, we don't have the liquid AZT for the infant, just go to a pharmacy. And that is not adequate, nor is it appropriate in this era. Hospitals, birthing centers who are taking care of women with HIV should have liquid AZT available, or they should be participating in the Baby RX Express program. And then finally, part of that case management is the follow-up for that infant. This slide just reminds us about the Baby RX Express. Hospitals can identify themselves when they know that they have had HIV-exposed infants delivered, and that hospital with a perinatal nurse or even an obstetric nurse can go to the nearest Walgreens and utilize a voucher provided by the state, the Florida Department of Health providing that, and then obtaining that retrovir for the infant for 6 weeks. Ideally, before the infant is carried out the door, that family and mother should have at least a 2-week supply of retrovir in hand, and they should have the syringe which they're going to use to provide that medication to the infant. The syringe is often a 1 ml syringe with gradations through 1 ml because the dosing based on the concentration is actually a very, very small dose. That's part of why infants, I think, tolerate the retrovir so well. I'm going to transition over to a couple of cases and raise some questions for you. Hopefully that will reinforce some of what I've said before, and potentially it'll stimulate questions in you as we go forward. The first case is a 24-year-old pregnant woman who presents to labor and delivery at 36 weeks gestational age. She reportedly has had no prenatal care since the first trimester. She says her HIV test was initially positive in this pregnancy, but this was the first time that she was tested for HIV. She does not have or know the exact results of her test. She does not know her viral load or CD4 counts. So when does most of the transmission occur? Does it occur prenatally during pregnancy? Does it occur perinatally around the time of labor and delivery, or does it occur postnatally? And so this is an important question. And in this scenario, what action should any of us be taking to try to protect this infant? First of all, natural history tells us that approximately 1/3 of all perinatal HIV transmission occurs during pregnancy. It does not occur in any specific trimester, as you might remember for rubella. And 2/3 of transmission occurs at the time of delivery. There is an additional risk of transmission due to breastfeeding, and that adds an additional 14 to 21% transmission due to breastfeeding or potentially other exposures, i.e. the pre-masticated food that I mentioned earlier. In Florida, with our current system of intervention, particularly third trimester testing and the initiation of antiretroviral therapy for mothers, even in the last trimester, the use of intravenous zidovudine during labor and making sure that infants are provided oral zidovudine for 6 weeks postpartum, we now see that about 2/3 of the infected infants who've been born in the last several years, 2005 to 2008, they were affected prenatally. Why did that occur? It's because of the interventions we're doing at and around the time of delivery. We decreased the viral load in mothers. We decreased the viral load in her blood actually at the time of labor and delivery. And then by providing the infant with that prophylactic AZT, we are, again, adding to that prevention of perinatal transmission. Here's a second case. A 34-year-old pregnant woman with HIV infection, again presenting to labor and delivery in active labor. She's been on and off antiretroviral therapy for about 6 months. She reports that she's been taking her medicines and has been well throughout pregnancy. She thinks her viral load was less than 50 the last time it was tested, and her CD4 count was 450. There are 2 older children who are 16 months and 36 months old without any documentation of their HIV status. So what other information would be helpful to manage this infant's care, and what testing should be ordered for the infant? And what would constitute appropriate follow-up for this infant? So this should reinforce many of the things that I said through the talk. The other information crucial to this is, if possible, getting all of mother's records to understand what her viral load is, to know exactly what her antiretroviral therapy has been, period. Additionally, you would want to know if there were any other STDs that this mother had, and the reason is because that would increase the risk of transmission to this infant. The testing that should be ordered for the infant is that HIV DNA or RNA PCR testing. That should occur at 2 to 4 weeks and 4 to 8 weeks, and then finally that ELISA at 18 months. And the most important other piece is the oral zidovudine for the infant for 6 weeks to prevent transmission. So things to remember about perinatal HIV prevention: postpartum zidovudine for the infant, consulting or referring to either a pediatric infectious disease specialist or someone who has additional experience with HIV, and in particular caring for infants exposed to HIV. That crucial follow-up, remembering that it's not just for the infant, it's also for the mother. Mothers need to stay well to be able to take care of their infants. And then that testing, as I've noted for you, for the infant through 18 to 24 months of age. I'll stop there, and we can entertain some questions and answers.
All right, Dr. Lawrence, there's one question here. If rapid testing is conducted in labor and delivery and resulted in a positive result, is there a need for another test before medications are started for this infant? Or is it necessary to treat the infant as if this child were HIV exposed?
First of all, rapid testing as done in labor and delivery is done for the mother. We're not testing the infant. If there is a positive result, then we should be telling that mother that result. We should be offering IV AZT if the mother is in labor at that time, and we should be then providing zidovudine for the infant for 6 weeks postpartum. That is an important time to also consult a specialist in pediatric HIV, because they might also advise the use of nevirapine in that scenario to additionally try to protect that infant. Nevirapine is not provided to the mother, it's provided to the infant, usually in 2 doses, one hopefully within 4 to 6 hours after delivery, and then a second dose at 72 to 96 hours. So additional testing of that mother at that time, quote, confirmatory testing, is not required for those interventions. It is necessary and appropriate to do that confirmation testing, because then if the confirmatory testing actually demonstrates that the mother is not infected, then you can stop the zidovudine in the infant. Does that make sense? You're trying not to miss that opportunity for intervention And so you're using that single positive test in the mother to do that intervention, and then you would additionally do confirmatory testing for the mother to further guide your next steps in taking care of that mother and infant.
Thank you, Dr. Lawrence. Now, we have another question, and I'm going to read that to you. In the scenario that we discussed before, Loretta says, I had a situation where the mom's Western blot came back negative. The child received approximately 5 days of AZT. Would that child need any follow-up as related to the use of this antiretroviral, or in result to the exposure to the AZT?
So there actually, I hear the question about the exposure to AZT. I have another thought about that scenario. But relative to the AZT, 5 days of exposure is not a significant exposure. There is no reason to, quote, expect that that child will experience any problems due to AZT. Remember, we've been providing AZT for infants since 1992 and 93, and these are HIV-exposed infants. And large cohorts of those infants have been followed for multiple years. All of those infants received AZT for 6 weeks, and those infants were followed for their ongoing growth and development. And there have been no clear problems or issues with that exposure. So a 5 days exposure, from my perspective, would be insignificant and not something that the infant would need additional follow-up. Having said that, I'm always a little concerned when one test is positive and the next is negative, and that ideally that mother would be provided additional follow-up and additional discussion about her risks, and potentially offered testing again to ensure that she knew, but also her healthcare providers knew, that she was absolutely HIV negative.
Now, Betty came back with this. One hospital may give a mom a few days of AZT to go home, but doesn't provide beyond that. She says that she's had 2 moms who said that they had trouble getting AZT because the pharmacy said the baby was not yet covered by Medicaid. And I'm sure that Betty is aware that the RX Express program is to fill in those gaps, to make sure that those mothers that don't go home with the AZT are provided it. And also, they will usually accept Medicaid up to 30 days after the mother has delivered the infant. The Medicaid covers the infant for up to 30 days. This is an ongoing problem. Dr. Lawrence, I'll let you address that also.
No, thank you for that. The other issue is if women have gotten some reasonable prenatal care, part of that care is really letting them know that the AZT for their infant postpartum is an essential part of this step, and even to go through some potential scenarios with them, i.e. if the pharmacy says, no, we won't give it, say, okay, how much does 2 days of AZT cost? Because, in fact, the cost for 2 days is going to be very, very small. And these pharmacies, once the Medicaid is approved, they can go back and get the full reimbursement for this. So moms we should be supporting moms, letting them know how important this is, and even thinking through with them some problem solving for some of the common problems that I know we've heard about and seen across the state. And so even this should not be something that is a problem. I do know that in some areas around the state, particularly with privately owned pharmacies, and I'm not using any names, that those privately owned pharmacies go out of their way to provide a liquid AZT for infants when they know that it's an issue in their own community. And they clearly make that effort. The bottle of AZT is a powdered formulation in a bottle that can sit on the shelf for 18 to 24 months. it does not need to be reconstituted until the infant is there in front of you or the mother is there trying to get that prescription. And so pharmacies can keep that on their shelves for long periods of time without any significant expenditure or loss of money / revenue from that. So there's no excuse for pharmacies not to have this available for infants. The same thing is true for hospitals. There's no reason for a hospital pharmacy not to have this. The expenditure for them is infinitesimally small compared to the cost of taking care of a HIV-positive infant.
And there are many hospitals in the, at least in the center of the state, that provide AZT so that the mother can take it home with the child. So that they have at least the dosing at that point in time. We do like to see dosing adjusted according to the weight of the infant as they get older, but we know from experience that it is still effective if they can get their 6 weeks.
The other thought I had, Millie, when you were commenting on adjusting the dose, that's a very important piece, is adjusting the dose. But that's why I said earlier that you want to make sure that that infant and mother has at least a 2-week supply. What you will find then is that at about that 2 to 3 weeks will be an appropriate time to adjust the dose in that infant. And so that's the opportune time to do that. And that's why I use that phrase about 2 weeks.
It's also one of the intervals that many of our physicians want to do the testing, the PCR.
Exactly, exactly. So those important next steps coincide at that time. And not counting that the mother or family could have 10 other questions and 10 other things. And they want to be able to ask those questions of someone who has spent a little bit of time learning more about this and takes a little bit more time making sure that the mothers and families really understand all the things that they can do to protect their infant and have a healthy infant.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.